Welcome to Academy of Ultrasound and our online echocardiography program. My name is John Sheldon, and this session I'm going to be leading. We're talking about part 2 of week 5 from Echo232, and we're talking about coronary artery disease, specifically in chapter 15 in your Feigenbaum book. Where we left off before was at this figure 15-15, dealing with abnormal geometry in the four-chamber view, or the short axis view. So if we go down to figure 16, figure 15-16 to continue forward, this gives us an idea of the standard segments of the left ventricle that are used for analysis specifically by cardiologists and specifically on stress tests, but also on regular echoes. It tells you at the bottom with the L, R, and C which coronary artery is actually delivering blood flow to those particular areas. So if you have a particular area that's being limited in its blood flow, that you're getting an abnormality in, for example, let's say we're getting an abnormality right here in the short axis view. We can tell that that's being delivered by the right coronary artery. If we got an abnormality here in the interventricular septum, we can tell that that's being delivered by the left coronary artery, and that is segment number 2. So you've got 17 segments, 17 being the apex, that you can use to diagnose or to try to discern exactly which segments are abnormal. The simplest assessment is a description of the wall motion as being normal, abnormal, hypokinetic, akinetic, or dyskinetic in each of the 17 regions. The next level of wall motion abnormalities deals with generation of a wall motion score, with each segment being normal, abnormal, akinetic, dyskinetic, or aneurysmal. A numerical score, usually 1 to 5, then is applied to each of these segments. The total score is divided by the number of segments to create a wall motion score. You'll see these specifically on stress tests, that you would actually have a wall motion score. Table 15-4, you'll notice, is right here, tells you the different segments and what they're referred to as. For example, number 3 is the basal inferior septal area. Let's go down to table 15-5. The wall motion score, you have mildly hypokinetic is 1.5, hypo is 2, severely is 2.5, akinetic is 3, so on and so forth. And then you divide that by the 17 to get a wall motion score. Strictly used for stress tests. The score is strictly used for stress tests. Completely normal wall motion would have a score of 1, with higher scores representing progressively greater degrees of ventricular dysfunction. Regional wall motion in ischemic syndromes can be obtained by application of Doppler tissue imaging. We call it TDI, or tissue Doppler. Doppler tissue imaging is used for both global and regional assessment of wall motion, as well as you'll also notice for diastolic dysfunction, we did Doppler tissue imaging on the mitral annulus. Major limitation of the technique can be employed in one region of interest at a time. Technology is under development to extract multiple Doppler velocities simultaneously, and it's called strain and strain rate imaging. Recently developed technique based on Doppler principles. Not many people in the field are using this at this point. Determination of myocardial velocities in 2 segments of the myocardium. Strain rate is defined as the rate of change in velocity between these 2 points. You look on figure 15-19, just to make you aware of it. You won't be tested on strain rate, but just to make you aware of what strain rate is, this is strain rate. It shows different images. You're picking different spots on the myocardium and actually getting a segment of flow showing how the wall's actually moving. Again, it's a brand new technology. It's something that you'll learn at conferences, and if your place uses it, they'll spend time developing that with you. You do not need to know this for the registry. You just need to know what strain rate is and be accustomed to hearing the term. And it is determination of myocardial velocities in two segments. Other technologies such as tissue characterization. This technique relies on evaluating the cyclic variations in backscatter. Again, this is something that's brand new. It's not being used in the field yet. Next, we're talking about contrast echocardiography. It's for evaluating capillary level flow in the myocardium. Tissue characterization, we use contrast injected into the heart, and you can see it perfuse into the tissue, and you can try to determine if perfusion is happening in a uniform manner. Again, this is not being used yet. Angina pectoris is an echo evaluation of a clinical syndrome. Angina pectoris is the first. Resting echo plays little role with exertional angina pectoris. Stress echo can play an instrumental role in establishing the diagnosis. So they come in, they claim they're having chest pains with exertion. Obviously, a resting echo is not going to do much to try to determine that. With clinical angina pectoris, a resting echo occasionally can provide information both exclusionary and confirmatory. So if they do have chest pains on exertion and you can find wall motion abnormalities from an old MI or a current coronary artery disease, can happen. So again, the echo may show information that can exclude problems or confirm them, specifically stress echo. Detection of regional wall motion abnormalities during ongoing pain is excellent evidence. Detection of resting wall motion abnormality can provide excellent confirmatory evidence. Again, you may or may not find wall motion at rest. That's the thing you need to be aware of. At rest, you may not always pick up coronary artery disease. Detecting other forms of organic heart disease can play an exclusionary role in evaluating patients with chest pain. If they're having an acute myocardial infarction, urgent transthoracic 2D echo plays a crucial role in the diagnosis of acute myocardial infarction and determine its location, extent, and prognosis. Classic inferior myocardial infarction with ST segment elevation and or Q waves in leads 2, 3, and ADF on the EKG typically involves segments bordering the posterior interventricular groove with variable involvement of the inferior posterior wall, which is the wall you see in the peristernal long on the bottom. They call this an ST segment elevation. They call it a STEMI. STEMI, ST segment elevation myocardial infarction, or a non-STEMI, which is a myocardial infarction without ST elevation on the EKG. Classic anterior and anterior lateral MI with ST segment evaluation and or Q waves in the anterior precordial leads involve the anterior septum, the anterior wall from the two-chamber, and the apex. So the EKG can give you indications of where you should specifically target your looking. Obviously, you target everything, but you specifically want to check these segments if you have ST changes on your EKG. Transthoracic echo is used to follow the progression of remodeling or regression of wall motion abnormalities. Let's go down and look at figure 15-32. Just because I'm not specifically going over all the figures in the rest of the book doesn't mean that you wouldn't want to be aware of those as we covered over them. I just want to bring certain ones to your attention while we're going through this lecture, but you still are responsible for recognizing and having reviewed the other images or figures. So this is a patient with an anterior impending ST segment elevation MI. It's a follow-up echo recorded several days after successfully reperfusing You'll notice that the ones on the top, dyskinetic. That's what these arrows are trying to say. The one on the bottom have preserved motion of the posterior anterior septum. So you'll see how it's uniform here. It's not uniform up here. I know it's hard to see in a still photograph, but be aware of what you're looking for. And let's look at 15-33. So this is an echo that's actually done 3 months after a person represented with a myocardial infarction. You'll notice how things have cleaned up, got a much, much nicer looking, not dilated any longer, much, much nicer geometry to the LV. Let's talk about prognostic implications. Adverse prognosis of wall motion abnormalities. In general, the more extensive the wall motion abnormality is, whether you're looking at EF or wall motion score, the greater the likelihood of complications such as CHF, arrhythmia, and death. Doppler evaluation of the systolic and diastolic function in acute MI. Doppler interrogation of the mitral valve inflow. Remember, diastolic dysfunction accompanies MI. Immediate reduction in left ventricular compliance at time of acute ischemia typically results in a reduced E to A ratio with a prolonged deceleration time. We've already talked about that. Complications of acute myocardial infarction. Mechanical complications can be visualized using 2D. Color Doppler flow is crucial for detection of lesions such as mitral and tricuspid regurg and ventricular septal defect. You want to be sure that you don't have regurgitation in your main AV valves, your mitral and tricuspid, because of acute myocardial infarction. We didn't cover it in this chapter, but there's also where you have papillary rupture, where it will actually rupture a papillary shortly after an MI and let loose of the chordae, which actually gives you blowing MR. So those are some of the things that you want to be aware of also. So that ends our talk tonight on coronary artery disease. As always, go to Google, other places on the web, search for coronary artery disease and echo. You'll find plenty of movies, pictures, videos. If something doesn't make sense to you, you can always send a link to it to john@academyofultrasound.com, and I'll be happy to look at it and try to help you interpret it. The more images and videos and stuff that you can find and see, the better qualified as an echo tech and the better able to take your registry you'll be. Also check your DVD that came with the Feigenbaum book for stuff that pertains to this thing. The more live pictures that you can get your hands on and take a look at, the better, more comfortable that you will be. So again, for the Academy of Ultrasound, this is John Sheldon wishing you well with your studies. Keep studying, and I look forward to seeing you at the next session.